Hi, my name is Tori and I am a doctor of physical therapy who specializes in pelvic dysfunction, which means I treat things that can go wrong around the pelvis, and this includes bowel dysfunction. After making a different video all about how to treat and prevent hemorrhoids, I've gotten a number of requests to make a similar video all about how to treat and prevent anal fissures. So that's exactly what we're going to get into today. We'll begin by talking more about healthy anorectal anatomy and function so that we can make more sense out of what anal fissures are, what their symptoms are, what causes them, what treatment options exist, and how to prevent them. As always, timestamps and links to any studies or resources mentioned today can be found in the description below, and without further ado, let's get into it. Let's begin by discussing anorectal anatomy and function with a heavy emphasis on the anal canal and anus. Imagine that this is a person who is facing you and has been cut down the center. Her rectum is here, sitting on top of her anal canal, which lives right above her anal opening, or her anus. For simplicity's sake, I want you to imagine that your rectum and anal canal look like a wine glass, where the rectum is where you'd pour the wine, and it's sitting on top of the anal canal, which is the wine stem. The rectum is where you store gas and poop before it's time to pass gas or have a bowel movement, in which case the gas or poop will move from the rectum through the anal canal, out of the anus, and into the world. Since we are talking about anal fissures, let's zoom into the anal canal and talk more about some of its structures and functions. So the anal canal itself is usually 3 to 5 centimeters long, and it can be further divided by something called the pectinate or dentate line. 2/3 of the anal canal live above the pectinate line, and that tissue is the same tissue that lives in the majority of your digestive tract. What's interesting about that tissue is that it doesn't communicate pain to your brain. Said another way, the tissue that lives above the pectinate line only communicates with your brain via stretch. It doesn't register pain the same way that other bodily tissue does, which is why internal hemorrhoids that live above the pectinate line are painless. However, the final third of the anal canal that lives below the pectinate line is made up of mucosal tissue, which is thin, soft tissue that lives inside of the body but is continuous with skin that is exposed to the external world. It's the same tissue that lives in your mouth, under your eyelids, inside of your nose, and in your vaginal canal, if you have one. And that tissue does communicate pain to your brain, which is why external hemorrhoids and anal fissures, both of which are located below the pectinate line, are painful. In fact, as we follow that mucosal tissue that lives in the bottom third of the anal canal down towards the anus, we'll run into another landmark, the anal verge, which is the name given to the transitional zone between the mucosal skin of the anal canal and the regular external skin of the anus. Understanding these differentiations and landmarks makes understanding everything to do with anal fissures so much easier. However, before we clearly define anal fissures, there are two more aspects of anorectal anatomy and function that you should understand. And those are two muscles, the internal anal sphincter and the external anal sphincter. I think it's easier to imagine these sphincters as two separate entities, where the internal anal sphincter lives at the top of the anal canal, right at the base of the rectum, or at the base of our wine glass, and the external anal sphincter lives at the bottom of the anal canal, just above the anus, or right where our wine stem would end. However, these sphincters actually have some overlap, where the internal anal sphincter is not only internal as in above the external sphincter, but it is also quite literally internal as in deeper in the body. It wraps directly around the anal canal, whereas the external anal sphincter is lower than the internal sphincter, but it is also quite literally external, as in the majority of it wraps around the internal sphincter, not the anal canal. This was harder for me to visualize localize at first, and what really helped cement it in my brain was making my own anal canal and my own internal and external sphincters, which I will share with you in a second. But the reason that I am harping on understanding the location of these two sphincters is because understanding this anatomy is really important when it comes to actually understanding causes, treatment, and prevention, especially treatment and prevention of anal fissures. If we pretend that this toilet paper roll is my anal canal, where my head is up towards the ceiling and my feet are down towards the floor, we can layer the internal and external sphincters separately to really see their overlap. This is my internal sphincter in white, and this is my external sphincter in yellow. Here is my internal sphincter wrapped around my anal canal, and you can appreciate that while the internal sphincter wraps around a lot of the canal, the bottom of the canal is still exposed. Then, if we add the external sphincter, you can see that while it does cover the bottom of the canal, the majority of it wraps around the internal sphincter. So, a quick review of everything that we've discussed before we properly define anal fissures. We've got the rectum, which stores gas and poop that lives on top of the anal canal and anus. When someone poops, that poop exits the rectum, moves through the anal canal and out of the anus into the world. When we zoom into the anal canal, which is about 3 to 5 centimeters long, we find the pectinate or dentate line. That line separates the upper 2/3 of the canal, which is made of digestive tract tissue that does not communicate pain to the brain, and the bottom third of the canal, which is made of mucosal tissue that does communicate pain to the brain. We will also find the anal verge, the transitional zone between the mucosal skin of the anal canal and the regular external skin of the anus, and we will find the internal and external anal sphincters, which work together to keep us continent. In other words, those two sphincters work together to make sure that we have control over gas and poop. Great! Now that we have a better understanding of anorectal anatomy and function, let's define the term anal fissure. Fissure is just another word for tear, and many of us have experienced fissures or tears on our lips. Cracked or chapped lips are actually incredibly similar to anal fissures, and if we wanted to use anatomically correct language, we could call chapped lips labial fissures. Similarly, the term anal fissure is used to describe a small, usually longitudinal tear within the anal canal that typically extends from the pectinate line down towards the anal verge. Anal fissures can vary in severity in that sometimes the tear is only in the mucosal tissue and other times the tear is deeper and it can expose the internal sphincter muscle or even the external sphincter muscle in some cases. Understanding the location of anal fissures within the anal canal, as well as understanding their varying degrees of severity, starts to make a lot of sense out of their symptoms as well as their causes. However, before we review those two topics, it is incredibly important to me that I firmly state that it is super important to get a proper diagnosis from a healthcare provider who actually performs a rectal exam and can tell you with certainty whether or not your symptoms are being caused by an anal fissure or something else. I say this for two main reasons. One is that anal fissures often get misdiagnosed as external hemorrhoids, either because the patient is self-diagnosing or because the provider is diagnosing without actually looking at the rectum and just going off of symptoms alone. Yes, external hemorrhoids and anal fissures do have very similar symptoms. However, if left untreated, an anal fissure is much more likely to become chronic. And while this isn't as common of an occurrence, it can also get infected, which can lead to abscesses and and fistulas. I expand more on those two concepts in the description below. Check it out if you're interested in learning more. The second reason is that the location and number of anal fissures can tell a provider a lot about your health. The vast majority of the time, there are one, maybe two fissures, usually located in the back center of the lower canal, sometimes located in the front center. However, fissures located on the sides of the lower canal or more than two fissures are both atypical findings and can be indicative of HIV, Crohn's, cancer, and other diseases. Of course, this is a rare finding, and I don't mean to scare you. I would just so much rather you find out if something is abnormal or atypical now than wait and find out later. So, anal fissures are small, usually longitudinal tears within the mucosal tissue of the anal canal that typically extend from the pectinate line down towards the anal verge. Knowing that these tears are located below the pectinate line, it starts to make sense that they would be painful, since that tissue is able to communicate pain to the brain. In fact, the two most common symptoms of anal fissures are pain and bleeding. More specifically, severe pain, especially after bowel movements that can last anywhere from minutes to hours, and fresh, bright red blood that can either be seen on the toilet paper after wiping, on the stool in the toilet, or both. You might also experience burning and or itching around the anus, especially after bowel movements, kind of like when you reopen a healing paper cut. If you investigate, you might be able to actually see a small tear right around your anus, depending on the location of your anal fissure, and you might also be able to see a small lump or even a skin tag right at the lower end of the fissure. The duration of symptoms is actually what defines whether an anal fissure is considered acute or chronic. And while the exact time frames vary depending on the source, I think it's safe to say if you have a recent onset of symptoms and you've had them for less than 8 to 12 weeks, you have an acute anal fissure. Whereas if you've already had a fissure and this is a reoccurring issue, or if you've had your symptoms for longer than 8 to 12 weeks, you have a chronic anal fissure. That differentiation is much more important when we start talking about different kinds of treatment. But before we discuss treatment, let's talk about causes. So, when we ask what causes anal fissures, what we're really asking is what causes the mucosal tissue in the anal canal to tear or chap or crack? And the answer is trauma or injury that either stretches the anal canal too much or makes the skin dry and more prone to tearing. Just like when you get a crack in the corner of your mouth from opening your mouth too wide, especially when your lips are dry. Anal fissures are often caused by constipation, by dry, hard stool that stretches the anal canal and causes that skin to tear. However, anal fissures can also be caused by diarrhea, because diarrhea can make that mucosal skin and the anus a lot drier and more prone to tears. I think that constipation causing anal fissures makes a lot more sense intuitively than diarrhea does. So if you're struggling to understand why diarrhea would make your skin drier, think about your lips. You don't hydrate your lips by putting water on them, and if you lick your lips too much, it will actually dehydrate your lips. And that's because both of those activities strip your lips of their natural oils, and that's what's going on in your anal canal and your anus. Anal fissures can also be caused by pre-existing inflammation within the anal canal, because inflamed tissue is already more stretched and less forgiving than normal tissue is. And finally, anal fissures can also be caused by both childbirth and anal play, as both activities can put a lot of stretch and cause a lot of movement inside of the anal canal. What whatever the cause of the fissure may be, that fissure causes pain, and that pain causes the anal sphincters, especially the internal anal sphincter, to spasm or guard or protect. Think about how any other muscles in your body respond to pain, injury, or threat. If I were going to punch you in the stomach, for example, your abdominal muscles would tense up to try and protect you. Your anal sphincters are doing the exact same thing. They are responding to pain and trying to protect you from that pain. However, even though their intentions are so good, when they spasm, it causes an increase in pressure in the anal canal, which causes a decrease in blood flow to the fissure, which can impair and prolong its healing. Bowel movements tend to cause more pain, which leads to more spasm, which leads to less blood flow, and the cycle continues. So all treatment strategies are aimed at interrupting that cycle so that the fissure can actually heal. As an aside, you may be more prone to anal fissures if your anal sphincters are already spasmed in response to something else, like a recent anorectal surgery, for example. The treatment options exist on a spectrum. From most conservative to most invasive, we have natural home remedies, which usually have to do with establishing a bowel routine. Then we have medications, and finally we have a couple of surgical options. Let's start on the most conservative end of the spectrum and walk through each of these options together. The conservative options will likely be the most helpful if you have an acute fissure. However, I do firmly believe that pairing the conservative stuff with medication or with a surgical option would only better optimize the outcome of either intervention. If it were me and I were opting for medication or I were opting for one of the surgical options, I would definitely pair the conservative stuff with either one of those interventions in hopes of optimizing my healing. Finally, the conservative interventions will not work if you don't commit to doing them every single day for at least 2 to 4 weeks. If it were me, I would commit myself fully to the conservative stuff for a full 4-week period and then reassess at the end of that time. So with that being said, the primary #1 conservative treatment option is to normalize your stool consistency for the duration of your healing. Constipation and diarrhea are the most common causes of anal fissures, and they will irritate and even worsen a healing fissure. So normalizing stool consistency is super important when you're healing. Sometimes that's more straightforward, like increasing your fiber and water intake if you're constipated, or eating stool bulking foods that won't irritate your digestive tract, as well as increasing your water intake if you have diarrhea. However, sometimes normalizing stool consistency can be a little trickier. So if you're someone who isn't quite sure how to normalize your stool consistency, it might be worth considering taking stool softeners or antidiarrheals just for the duration of your healing, because you can always address your stool consistency once that anal fissure is totally healed. Many people with anal fissures will become fearful of bowel movements because they don't want to experience pain, and sometimes people will actively try to avoid having a bowel movement for this reason. Of course, this line of thinking makes so much sense, and it is totally human to have that kind of response. However, actively avoiding bowel movements will actually make your stool harder and drier. That's because as you continue to ignore natural urges to defecate, the stool sitting in your rectum will actually be lifted up into the end of your intestines, into your sigmoid colon, and your colon will extract more water from it before placing it back down into your rectum, making it harder and drier. So even though avoiding bowel movements and suppressing those natural urges is a completely human response, please don't do it. It will make the fissure worse in the long run, since it will make your stool that much harder and that much drier when you eventually do have a bowel movement. Instead, let's talk about a bowel routine that you can implement to not only decrease pain during bowel movements, but also to make your fissure less irritated during those bowel movements, which will hopefully help it heal faster. First, before you sit down to defecate, you want to protect your healing healing fissure by lubricating it and your anal canal. You can use coconut oil or any over-the-counter water-based lubricant that you like. Remember, anal canals are 3 to 5 centimeters or 1 to 2 inches long, and anal fissures live in the bottom third of the anal canal, so inserting your lubricant of choice a half to full inch inside of the canal before you defecate should lubricate and protect the fissure. Next, you want to sit on the toilet properly when you poop and avoid straining. I have a different video that goes into a lot of detail about how to sit on the toilet properly to poop and why, and I will link it here as well as in the description below. But for now, trust me when I say that sitting incorrectly and straining both make it really, really challenging for the internal and external sphincters to relax, which is going to make the fissure worse. Once you are done pooping, don't hang out on the toilet. Western toilet seats actually have a constricting effect, and prolonged sitting can cause the vessels in your anal canal to swell, which increases the pressure inside of your anal canal, which makes it more difficult for a healing anal fissure to actually heal. And that increase in pressure also increases the risk of developing hemorrhoids. So once you're done, get up and don't hang out any longer than you need to, especially if you are trying to heal an anal fissure. So now that you have lubricated your anal canal, sat properly on the toilet to poop, and you've gotten up right away because you are done, it is time to clean yourself. If you are using toilet paper, try to purchase softer toilet paper and wipe yourself gingerly and gently. Rougher toilet paper as well as really enthusiastic wiping can both irritate that anal verge area, which can irritate the lower portion of a healing anal fissure. In an ideal world, you wouldn't be wiping at all. If you're open to it, it might be worth considering a bidet. There are plenty easy to install and relatively affordable bidets in the $25 to $35 range available online, or if you don't want to go through the hassle, you could just splash your buttocks with some water and then pat it dry, or even use a hair dryer to dry yourself. Wipes are also an option. However, if you do choose to use wipes, be mindful of the kind of wipes that you buy. You do not want scented wipes, nor do you want wipes that have alcohol in them. Perfumes and alcohol can both aggravate healing tissue. Alright, so you've lubricated your anal canal. You have sat properly on the toilet to poop. You have gotten up when you're done, no dilly-dallying, and you have ideally used water and let your buttocks air dry. Your next step in an ideal world would be to have a 10 to 15 minute sitz bath. Now, I know that taking a 10 to 15 minute sitz bath after every bowel movement isn't possible or practical for everyone, so do the best that you can. However, do carve out time to take at least 2 sitz baths a day, one in the morning and one before bed. Sitz baths are incredible healing tools for anal fissures because the warm water helps the anal sphincters relax, it increases blood flow to the area, and the baths can be very soothing and ease the discomfort of fissures, especially after bowel movements, which feeds back into less anal sphincter spasming. So whether you are taking a sitz bath right after a bowel movement, independent of a bowel movement, or you had a bowel movement and you weren't able to take a sitz bath, the next step is to make sure that your anal area is dry. Consider applying some baby powder, not only after bowel movements and sitz baths, but also after showers, exercise, or any other activity that gets your buttocks wet or promotes sweat. Baby powder is great because it's gentle, it keeps the area dry, and it helps to decrease friction and rubbing, both of which can irritate a healing anal fissure. If you're someone who prefers more natural products, you can also consider the cornstarch-based baby powder as opposed to the talcum-based. waste baby powder. If you want, you can also consider minimizing or even eliminating exercise and other sweat-provoking activities just for that 2 to 4 week healing period to better optimize your healing environment while your anal fissure heals. Alright, so that is the bowel routine. Before we talk more about medications, there are a few other conservative interventions that we should discuss. 1, don't itch. Anal fissures can be itchy, especially when they're healing. But scratching can not only reopen and prolong the healing of an anal fissure, but it can also lead into a really vicious anal itch cycle. Instead of itching, opt for a sitz bath or some baby powder. 2, if you have to sit a lot for work or you just find that you are sitting often, you can use a soft, gel-filled cushion or pillow to alleviate some of that sitting pain. However, do not use a donut-shaped cushion. That donut shape is the same shape as the Western toilet seat, and it can have the same constricting effect. And finally, number 3, if you are someone who enjoys anal play, please do avoid anal play throughout the duration of healing your anal fissure. Okay, now that we have discussed the conservative treatment options, let's talk more about the medication options, which are usually prescribed to someone who is trying to heal a chronic anal fissure. There are 2 common and effective medications that are often used to treat anal fissures, and those are topical nitrates and topical calcium channel blockers. Both of these medications can cause a drop in your blood pressure, so if you are taking either one of them, please perform transfers slowly. That means when you are going from a laying to a seated position, or especially if you're going from a seated to a standing position, move slowly, because if you move quickly, that drop in your blood pressure can cause you to faint. So topical nitrates, usually nitroglycerin, work by chemically relaxing the internal anal sphincter. When that sphincter relaxes, the pressure in the anal canal decreases, which means blood flow to the fissure increases, promoting healing. Topical nitroglycerin is effective in about 50% of chronic anal fissure cases. However, it does commonly cause headaches as a side effect, and sometimes those headaches are severe and debilitating enough that they will cause the person to stop using the topical nitroglycerin, and that happens maybe 20 to 30% of the time. Topical calcium channel blockers, on the other hand, work very similarly in that they also chemically relax the internal sphincter. However, side effects, notably headaches, are significantly less frequent than those experienced with topical nitrates. Calcium channel blockers are also arguably more effective than topical nitrates in that they heal about 65 to 95% of chronic anal fissure cases. So if it were me and I had a chronic anal fissure that wasn't responding to conservative treatment, I would likely pair that conservative treatment with a calcium channel blocker instead of a nitrate. Not only because the calcium channel blocker is less likely to cause headaches, but also because the calcium channel blocker has a higher healing rate. Also, if you choose a topical medication in order to treat your anal fissure, be consistent with its use. Use it as it is prescribed. There is evidence to suggest that one of the reasons that both topical nitrates and topical calcium channel blockers aren't as effective is actually because people either don't apply them as often as they should, or they stop applying them before they are supposed to stop. So take that personal responsibility in your healing and use them as they are prescribed. Finally, I did want to mention that sometimes lidocaine, which is a topical numbing cream, is recommended for pain management, and that's totally fine. You can absolutely use lidocaine cream if it is a safe and good option for you. However, it is incredibly important to remember that just because something is numb, just because you can't feel something, doesn't mean you can't irritate it, hurt it, or re-injure it. So if you are using lidocaine cream, I highly recommend that you still stick to those conservative treatment options that we outlined earlier so that you don't accidentally hurt yourself and end up prolonging your healing. And I also wanted to mention that opioids are not a good pain management option when it comes to healing anal fissures because opioids very often cause constipation. All right, let's talk about the two most common surgical options before we finally discuss prevention. The two most common surgical options for treating anal fissures are Botox injections and a procedure that is called a lateral internal sphincterotomy. Both procedures are typically outpatient, and both procedures aim to relax that internal anal sphincter muscle in order to promote healing. However, although the risk is relatively low, both procedures also carry the potential risk of developing fecal incontinence or losing your ability to control gas and stool. Botox relaxes the sphincter by paralyzing it. Botox is injected directly into the anal sphincter muscle and causes temporary paralysis, which allows the muscle to fully relax. Botox has a healing rate of about 50 to 80%, which is better than topical nitrates, but pretty equal, if not a little worse, than topical calcium channel blockers, and it is significantly more expensive than topical medications. If the injection accidentally damages the internal sphincter, it can cause fecal incontinence. A lateral internal sphincterotomy, on the other hand, releases the sphincter by making a small incision in it. Cutting a small portion of the internal sphincter in this way reduces both spasm and pain, which both promote healing. Lateral internal sphincterotomies have an amazing healing rate of 90 to 100%. However, if the incision accidentally damages the internal sphincter, that risk of fecal incontinence still exists. I mentioned earlier that if I were navigating a chronic anal fissure that wasn't responding to conservative treatment, that I would likely pair that conservative treatment with a topical calcium channel blocker over a topical nitrate because the calcium channel blockers have both a higher healing rate and a lower risk for developing headaches. I would also likely choose the topical calcium channel blocker over Botox injections, and that's because there's pretty good evidence to suggest that they have pretty similar healing rates, and topical calcium channel blockers are significantly less expensive than Botox, and calcium channel blockers do not come with a risk of fecal incontinence, where Botox injections definitely do. Finally, if the topical calcium channel blockers were failing me, I would also likely opt for the sphincterotomy over Botox injections, and that's because while Botox and the sphincterotomy both carry a relatively low risk for fecal incontinence, the sphincterotomy has significantly higher healing rates. If you want a consolidated written review of the pros and cons of the pharmaceutical and surgical options, check the description below. Before we wrap up, let's end by discussing prevention. Unfortunately, anal fissures can reoccur relatively easily and they can't always be prevented. However, one of the best things that you can do to prevent them is normalize your stool consistency. Constipation and diarrhea are not only the most likely causes of anal fissures, but they are also the most likely causes of reoccurrence. So normalizing your stool consistency, and also if constipation and diarrhea aren't your norm, treating them immediately when they happen, especially diarrhea, can both be really helpful ways to prevent anal fissures from reoccurring in the future. Otherwise, parts of the bowel routine that we discussed earlier can be adopted as preventative measures. Sitting on the toilet properly to poop to promote anal sphincter relaxation. Getting off of the toilet right away when you're done instead of hanging out. Opting for softer toilet paper or even a bidet so that the anal skin isn't rubbed and irritated. And making sure that the anal area is dry, whether that's by pat drying with soft toilet paper or using a hair dryer or applying a powder after wetter bowel movements or before sweat promoting activities. Just being more mindful of that that anal skin is really helpful. Finally, a few long-term preventative considerations include 1, weight loss. The heavier that you are, the more likely you are to sweat, the more likely you are to have wetness, which can cause irritation and rubbing in that anal area. 2, if you are someone who is enjoying anal play, be sure to use plenty of lubricant and stop playing if something hurts, especially if it feels like tearing. And 3, if you are someone who is suspecting that your fissures might be caused by an underlying spasm, an underlying internal and or external anal sphincter spasm, you may want to consider pelvic physical therapy. A pelvic physical therapist would be able to help you treat that anal spasm. So I will link to a directory down in the description if that's something that interests you, to help you find a provider in your area. On that note, thank you so much for watching. If you enjoyed this video or found it helpful, please do give it a thumbs up, and if you didn't like it, do give it a thumbs down and let me know in the comments what I can do to improve in the future. Feel free to comment absolutely anything down below. Questions, content suggestions, feedback, really anything. I do try really hard to read and respond to all of my comments. Don't forget to check me out on Instagram, and finally, if you want to see more content from me, please do consider subscribing to the channel. I make videos not only about pelvic things, like today's video, but also about life things. Thank you again so much for watching. I hope that you have a wonderful rest of your day, and I will see you in the next video. Bye.